रियल है मैम।
मैडम एक मिनट है। Sir, good evening, sir. Good evening, doctor. Myself is sales manager with my colleague Mr. Sachitra. Doing this webinar regarding the reduction of dosage reduction strategy. A very good evening to all eminent doctors. Thank you so much for joining us for today's webinar. Our endeavor is to spread awareness about the rabies, which is fatal but can be avoided once appropriately vaccinated. This is an initiative from Kadila through its innovation to serve society and humankind. The topic of the webinar is dosage reduction strategy in rabies management role of novel vaccine. Dear Doctor, Thabis is world's first novel three-dose anti-rabies vaccine, and with great pride, we would like to inform you that Thabis has successfully completed 1 year of launch, with more than 40,000 animal bite victims being vaccinated. 100% compliance was recorded, and no case of uh, adverse reaction was administered. With this, it is my honor to introduce you to the speaker of today's webinar, Dr. Tapas Ranjan Behera, specialist in MD SPM. Uh, related to now, I would like to request Doctor to start initiate the talk, and later on we would have a question and answer session.
Thank you, Satya, for your nice introduction of the topic and mine. Good evening, one and all. It's my pleasure to be speak before all on a topic which is now the need of the hour because of many reasons, and we all know that the animal bite victims, which can lead to a dreadful disease called rabies, is it can be preventable 100% if we, as a physician or a clinician or practitioner, rightly at time at administer the treatment in form of anti-rabies vaccines and either immunoglobulins or monoclonal antibodies. So, taking into this consideration, there are many reasons why we are now gathered to know more, something new about the compliance of the treatment protocols or the compliance on part of the patient and also on part of the doctor to give uh, some reduction in form of maybe the duration of treatment, maybe the peak, maybe the cost factor, maybe the adverse events following vaccination. So there are many reasons which are responsible for the dropouts or delays of the treatment, which can lead to or which might have also led in previously the death because of rabies. So coming into the topic, which Satya has nicely said that the today's topic is entirely based upon compliance on treatment protocol of the new molecule or the new vaccine has been launched in India, or probably this is first kind of in the world that a vaccine which has come for with a weekly regimen and reduction in the visits of the patient. So, whenever we talk about rabies, we all know that India being one of the countries in the world which accounts more number of deaths because of rabies. And if you go by a WHO and the association where I am a member, and the Association for Prevention of Control of Rabies in India, they have published their study in collaboration with WHO way back. There are two studies conducted by multicentric studies by WHO APCRI in 2017 and also recently 3 years back 2020 pre-COVID. globally, we all know that 59,000 human deaths annually occur, and especially they are highest in India. And India had 20,000 human deaths a year from rabies, accounting 60% of rabies deaths in Asia and 30% globally. So if you see this number, and 91% deaths in India occurred, especially in rural areas. And these are there are many reasons why deaths occur mainly in rural areas, relating to it to be non-reporting to the health facility following a animal bite or a dog bite, or maybe the ignorance in part of the patient in attending to a traditional healers like a Ayurvedic or any traditional healer in that area, or even not completing the treatment also. So there are many reasons of these deaths in rural areas. And urban areas, we know that because of there are some availability or accessibility to healthcare facilities, so the cases are not so marked in urban areas. So if you see that every 9 minutes a person dies of rabies, and we are talking about rabies in this forum in the evening today, and a patient or a human being or a child or a woman might have died in some part of our country or in the world. So taking into this scenario, we have the current management of animal bite. And as I say, there are three pillars. I say always to remember in three forms that there are three wickets in cricket. So there are three pillars of the current management of animal bites also. So first is the local wound treatment, that is the first aid. Then is the active immunization through the anti-rabies vaccines. Then a passive immunization, that is immunoglobulin administration in case of category 3 bites, or in case of category 2
डॉक्टर तपस
yeah.
सर आपकी ना स्लाइड मूव नहीं हो रही है, नेक्स्ट कर दीजिए वो.
Oh, I thought he will be doing the next, because I
नहीं
don't.
सर, एक्चुअली मुझे हाँ बस ओके.
No, just
I
inform me
thought-
when I have to do next. Okay.
हाँ
Okay,
नेक्स्ट ओके.
okay, because he is sharing the slides, so I thought. Okay. We can go for the next. Next slide, please. Yeah. So this slide. So should we start now?
यस सर, यस सर.
Yes, sir.
Okay, thank you. So talking of the current management of animal bites, as I said, I am very fond of cricket, and recently we are into the World Cup, and now the topic is on cricket. And if we say that there are three wickets in a cricket to a batsman face, so similarly in animal bite management, there are three pillars, three wickets. First is the local wound treatment, that is the first aid. Second is the active immunization, that is the anti-rabies vaccine administration. And third is the passive immunization, that is the rabies immunoglobulin, or recently the rabies monoclonal antibodies have been discovered and been in use. So these are the three pillars of management. And the first management, or the first pillar, that is the local wound treatment or the first aid, it carries a vital role in treatment of animal bite. And this is to be followed, or this is to be ventilated, or this is to be advised to each and every patient who comes after a animal bite, that washing the bite wound with soap and water for at least 10 to 15 minutes under a running tap water, or even pouring water into that bite wound, it can reduce the virus load up to 85%. And because of the detergent action of the soap, it kills the virus also. So it has a major role, the local wound treatment. The second is, and the wound management also, the first point is here also, that we should not bandage any wound. if there is active bleeding and the bleeding is not stopping by the pressure bandage also, then we can go for any stitch of the wounds. But preferably, we should not cover the bite wounds with the bandage, and we should not suture the bite wounds. If there is if there is no stoppage of active bleeding, then we can go for suturing of the wounds. But preferably after giving a tetanus toxoid injection also for toxoid prophylaxis, and then applying a virucidal agent. The best example of virucidal agent is povidone iodine. It has virucidal capacity, so that the povidone iodine lotion or even the ointment, it has virucidal capacity to kill the virus also. So the wound treatment compromises of again three, that is washing of the wound, not covering the wound with any bandage unless there is no non-stoppage of the bleeding, non-suturing of the wound, and third is also applying of virucidal agent like povidone iodine. Then coming to the second point, that is active immunization. We have different anti-rabies vaccines. I'll be discussing in brief about the different types of vaccines in my next slides. So the active immunization is administration of anti-rabies vaccines. And third point is administration of passive immunization, that is rabies immunoglobulins or even the rabies monoclonal antibodies. So presently the guideline says that as per the intramuscular regimen, this is called SN regimen, intramuscular regimen. So there are 5 doses of intramuscular vaccine to be given on 5 different days of their visits. That is, we say that day 0, day 3, day 7, day 14, and day 28. And day 0 is not the day of bite, it is the day of visit to the healthcare facility for administration of the vaccine. The day when the first anti-rabies vaccine is administered, that is the day 0. It's not the day of bite or day of attending. The vaccine administration day is called the day 0. So these 5 visits, day 0, day 3, day 7, day 14, and day 28. There are 5 visits in a month. So the treatment is lengthening. It's a 1 month period. So, and preferably the RIG, I was talking of the passive immunization, that is the rabies immunoglobulin, that is to be given preferably on day 0. If at all there is non-availability of the RIG, or even the patient cannot afford, or even there is non-availability in a health facilities, but this immunoglobulin can be given till day 7, not after day 7. So the immunoglobulin has to be given in all category 3 exposures. That is, the definition of category 3 exposure says that where there is oozing of blood from the bite wound. So it is called category 3. So the vaccine is given for category 2 and category 3. For category 3, we are giving vaccine and immunoglobulin. Category 1, we do not need any treatment because that category 1 says that only touching of a animal. So the treatment of intramuscular regimen, I say again, there are 5 doses. So there are 5 visits and the period is for 1 month. So again, emphasizing on day 0. Day 0 is the first day where the vaccine is given, anti-rabies vaccine is administered. That we count as day 0. Again on day 3, day 7, day 14, and day 28. And these vaccines, the intramuscular regimen vaccines, anti-rabies vaccine, has to be given intramuscularly in deltoid if the age of the child or the man is above 5 years of age. If the children, it has to be given in thigh, lateral aspect, anterolateral aspect of the thigh. And these vaccines should never be administered in gluteal regions. The reason being, in our gluteal region, there are more fatty tissues which hampers the absorption of the vaccine, and it reduces the production of the antibody. So it should not be given in gluteal region. Rather, none of any vaccine should be administered in gluteal region. Let it be tetanus toxoid vaccine, let it be any vaccine. So that should be the take-up point. Next slide, please. Well, there are many challenges in the present post-exposure prophylaxis, as I said. Number one being the non-compliance. It may be because of many reasons, because of the lengthy treatment period that the patient has to come repeatedly visits over a period of 1 month, and the current rabies vaccines, which are all cell culture vaccines, and the technology, this cell culture vaccine technology is way back, is much more than 50 years old technology. So maybe the technology we are adopting the old technology of the cell culture vaccine, which have maybe in some inconsistency in the potency. Maybe there is some stability in the vaccine. Maybe these cell culture vaccines, they are usually the short supply or the availability are problem, and moreover there are many adverse events or side effects following these vaccinations, the cell culture vaccines. So need of the hour, taking into all these three challenges, the current challenges in the treatment protocol of animal bites, we have come up. The first is the non-compliance. If I go the non-compliance to how to address the non-compliance. Next slide, please. So if you come up with the compliance of the anti-rabies vaccines, the compliant is who received the full course of anti-rabies vaccines, that is the scheduled doses of ARV on the recommended dates. So usually the day 0, day 3, day 7, day 14, and day 28 as per the intramuscular regimen, which we call it as a SN regimen. If a patient of animal bite has completed all these 5 doses along with also the immunoglobulin, then we say that there is compliance. So delayed compliance means a patient who has completed the scheduled dose of ARV within 60 days, within 2 months of period, but deviated from the scheduled regimen, means not coming on the particular date of the scheduled date. And dropout or non-compliant, the patient who had not taken at least 1 dose of ARV after animal diet and not completed all the scheduled doses. So that we say that it is non-compliant or the dropout. So the main reason of, next slide, please. So the main reason of non-compliance of 5 doses, there are many studies have been published in different journals. If you see, these are the 3 studies. The present slide is being focused. If you see the first case, the 58-year female, the nature of animal bite was a street dog and the dog was killed soon. So maybe it was a rabbit dog. That's why the nearby people have killed that dog. So the post-exposure prophylaxis, the patient has taken 3 doses of PCEC, purified chick embryo cell culture vaccine, that is the Rabipur, but the patient has not taken any rabies immunoglobulin. So the findings, they say that when it was admitted at the hospitals, the dog bite category 3 at the right side of the nose, 20 days period, there was some development of paresthesia of face, 20 days. There was fever also, there was altered sensorium also, restlessness. So with these symptoms and signs, the patient was admitted and the diagnosis was given as rabies encephalitis, and the treatment protocol was as the patient is in a clinical rabies have been diagnosed. So the outcome we all know, and might be because of that outcome, you can see from the slide, the outcome is hospital survival of 16 days, but died after 1 day due to lama. So the patient was admitted. She left without informing any authorities of the hospital, and that patient died after 1 day of lama, or 1 day following the from the hospital. So the patient was not discharged, but however, because of the consequence or the outcome they could know, so they left the hospital. So if you see the next two patients, similarly, they have taken 3 doses, and they have not taken rabies immunoglobulins, and the same thing, they could know the outcome or the consequence of the the patient. So the relatives or their family members, they have taken the patient to their house, and unfortunately they have succumbed. So here the point, or the I want to stress, is that the reason of death may be due to of lack of administration of rabies immunoglobulin, or even the poor compliance to vaccination. So here we can see that they have taken only 3 doses of vaccines. They have not completed the full course, that is 5 doses of anti-rabies vaccines. Next, please. Next slide, please. So there is a paper published in Journal of Family Medicine and Primary Care. The first author, Manasi Ponda, she is my undergraduate student when I was a assistant professor in a different college. He was doing her post-graduation, and her thesis was related to this. So I see her name, and it's a proud moment to see his name in a journal and being focused in a CME. So the study says that compliance to post-exposure prophylaxis among animal bite patients, a hospital-based epidemiological study. It was done at Safdarjung Hospital, New Delhi, among 360 animal bite patients, and there they found that 53% were non-compliant to the full course of ARV. So more than half, 53% were non-compliant to the full course of ARV. And the reason, and if you see, they have divided into three, into complaint, delayed complaint, and non-complaint. So together they can say that more than half were non-compliant to the full course of the Delhi. So it is a picture at Delhi itself, the national capital of our country, and we can see from here only that how the people are either accepting the fact that they cannot complete the full course of, because of many reasons. So we'll go to that also, what could be the reasons. Next slide, please. Another study published in Indian Journal of Public Health, which says that the compliance to anti-rabies vaccination in post-exposure prophylaxis, none other than by Aswath Narayan sir. They have found that in a municipality corporation hospital in Bangalore, which was done among 215 animal bite patients, and they have seen that on day 0, the patients who have all come, 215 patients, 60% they could come on day 28. So the decreasing trend is, even on day 3, 12% do not came. So 1 dose of rabies vaccine was administered intramuscularly on day 0, 3, 7, 14, and 28. This also measures constraints for compliance to complete course. So we can say that the compliance rate for intramuscular rabies vaccination was over 60%, means the patient are not turning up on day 14 or day 28. So till day 7, there was 85% compliance rate, means because of the shorter period, till day 1 week, all patients are preferably coming to the nearest health center for getting the vaccine. But for day 14 or day 28, they are not turning up. There are many reasons why they are not turning up. Maybe because of that, I will be sharing in the next slide. Next slide, please. So the major constraints for non-compliance to complete the ARB was the loss of wages. We all know that because as I said in my first slide, that 91% of the cases occur in rural areas. Let it be rabies death cases or let it be animal bite cases. So in rural areas, the patients usually are involved in either for daily worker or a farmer or in any farm or maybe a shopkeeper or maybe a driver or any occupation they are engaged in. They are fear that if they go for taking the anti-rabies vaccine to a patient, the whole day they will be engaged in getting that vaccine, and they will lose the wages or the income for particular day. So there are some constraints for compliance to complete the course of anti-rabies vaccines. One is we can see that even in children, we can see the interference with school timing. 10-11% they have in the school children, they cannot come because of the school timing also. 11% they said that because of the distance of the hospital, it may be more than 5 kilometers or 10 kilometers, they are not able to come, distance of the hospital. And 13% were said that they because of cost incurred, it is the indirect cost of the treatment. We said that everything is available free in a government hospital, let it be a municipality hospital or let it be in a government hospital. But the indirect cost, the travel cost, the food cost, those are the factors which have led those 13% patients as a non-compliance. So they do not return back to on that particular date, maybe day 7 or day 14 or day 28, because of this indirect cost that has to be borne by that patient. 18% said that they have forgotten the dates. They do not remember when to come back for the next vaccine. So it's an interesting finding. So the major constraints among all, if you see, 47% said that it's because of the loss of wages. The patient did not want to lose the daily income of that particular day and to get that vaccine. Next, please. So before knowing it, all these, the compliance or the non-compliance, reasons of non-compliance, if you go to the history of the particular rabies vaccine, say we all know that previously the anti-rabies vaccines were given over abdomen. वो बोलते थे कि 14 इंजेक्शन लगेगा पेट में. So those nervous tissue, NTV, normal tissue vaccines. So nerve tissue vaccines, those are the first kind of vaccines. Those are being used for any animal bite, let it be a dog bite, cat bite, or monkey bite. And previously it was given up to 31 injections. Then it was again modified into a inactivated form way back in 1911, and they say that it was given of 14 injections, 0.5 ml or even 0.1 ml if the weight is more or the age is more. So when I was doing my post graduation in Odisha in Barampur, 2002, I saw this vaccine was given. But after 1 year in 2003 and 4, the vaccine was even absolute from our country. So we, as a country in India, we were using nerve tissue vaccines till 2002. In the 20th century, we are able to going through those painful injections also over abdomen. Luckily, now presently, we are into the cell culture vaccines from 2000. Because of the cost factor, maybe the introduction was little late. However, these cell culture vaccines, way back it was introduced when I was born in 1976. Those are 5 injections given either in form of 0.5 or 1 ml. Those again on day 0, 3, 7, 14, and 28. Still, these vaccines are being used with a potency of more than 2.5 international unit per vaccine, whether it is 0.5 ml or 1 ml. Still. So next, what could be the newest possible? So there are changes. It says that in 1885 to 1976, and as I said, till 2002 we are using Noptisu vaccine in India, and it was out not being used in India anymore from 2003 probably. So what could be the newest or the new in the 20th century? Next slide, please. So the point which we all want to focus or well to know, the meeting the unmet medical need. So we have been talking about nerve tissue vaccine, then cell culture vaccines, the compliance of all these type of vaccines. Maybe because of some side effects and compliance, we could withdraw nerve tissue vaccine. And now, because of again some non-compliance of cell culture vaccines, are we prepared for a new technology, new vaccines? So the unmet need of medical need. So how to meet that? So introducing a novel vaccine with simple and shorter regimen was the need of the hour, and we could bring it, the newest vaccine. Next slide, please. So coming to the newest vaccine, novel 3-dose combinant rabies G protein vaccines. We can see this, that the first protein subunit vaccine, this is prepared by the virus-like protein platform technology, the VLP technology we call it. It's a new form of VLP technology. And the first vaccine with 3-dose intramuscular regimen, or we can say that is a weekly regimen in a week period, 037. On the 7 days period, we are just finished with the treatment, that is only 3 doses. And it's because of its better compliance due to its easy flow regimen and lesser visits. As I said previously, the non-compliance was because of the more number of visits to the hospitals, because of many reasons also. So it could meet that non-compliance. And it's a good thing is that it's a ready to use, so there is no need of reconstitution. So there is no need of the administrator, either the pharmacist or the staff nurse who is administering the vaccine. They will be in a hurry to reconstitute that vaccine and again draw it and give it. That takes around again 1 minute. So there is wastage of time in there. So it's a ready to use vaccine. It's available in the liquid form, so we need not have to waste for the reconstitution. So this is the novel 3-dose recombinant rabies G protein vaccine, which has the many advantages. As I said, the technology, the lesser visits, and easy to administer because it is ready to use. Next slide, please. So as I said that it is being with the VLP technology, something about this new technology we will be just going into in a half a minute. So what is this VLP technology? The new technology which has provided for the innovation to bring with a new vaccine with a lesser visits and lesser amount also, because it is 0.5 ml also and ready to use. It is available in liquid form. So we have the native virus. We can see it in the left, that is the native virus, and the G protein is very difficult to stabilize. And this G protein isolation, that is by using the virus like protein technology, and purified and stabilized by Cadila Pharmaceuticals Limited. So this is a new technology which have been taken up by Cadila Pharmaceuticals to prepare a virus-like protein. So these virus-like proteins are protein complexes which exist as nanoparticles, and these virus-like particles are similar to the native virus particles, but they do not contain the viral genome. So here, one thing, the importance is that the virus-like proteins are similar to the native virus particles, but they do not contain the viral gene. So they cannot replicate, but they can mimic the viral antigenicity without being pathogenic. So it has the advantage that it does not contain the viral genome, so that it cannot replicate, but it can also, advantage is that it can mimic the viral antigenicity without being any pathogenic. So they are capable of inducing a strong humoral and cellular immune response. Both they are capable of inducing the strong humoral and cellular immune response. And last, these BLPs, they act as the vaccines in the neotechnology, that is the BLP technology. Next slide, please. So before going into the particular vaccine, the BLP technology G protein vaccine, they have published a phase 3 clinical study in human vaccines and immunotherapeutics journal. That study is safety and immunogenicity of a novel 3-dose recombinant nanoparticle rabies G protein vaccine administered as simulated post-exposure immunization, a randomized comparator controlled multicentric phase 3 clinical study. And if you see the third author, Dr. Durga Satpathy, he is from Odisha. He is my mentor. So Odisha was one of the site for this multicentric study, and the comparator was one of the reference vaccine that is called PCEC, that is the Rabipur. We'll be just going into a brief about their study. Next slide, please. So this is one of the study which have included more number of subjects, more than 500 subjects, means more than 500 participants have been included in this study. So it's a unique in the sense that this study has more number of participants for their phase 3 clinical study. So there are two vaccines. One is the study vaccine that we are talking of is the Travis, the G protein vaccine, new G protein vaccine by the BLP technology. The comparator or the reference vaccine is the Rabipur. So these two vaccines were given in the randomization in the 2:1 in the sense that for every reference vaccine Rabipur administered, 2 patients were given Travis. So 2:1. So 2 patients with Travis, 1 patient with Rabipur. So the regimen was 037 for Travis and 5-dose regimen, that is SN regimen 037, 14 and 28 for Rabipur. So the objective was to evaluate the immunogenicity, and it was a multicentric study all over India, where Odisha was also a part of that study. Bangalore was a part of the study. So next slide, please. So coming into the results of this particular study, the efficacy and safety. If you can see the efficacy, the seroprotection, it is almost same or it's little more than the reference vaccine on day 14, and also almost same on day 42. So the seroprotection is achieved by day 14, which we call it that the protective value of 0.5 IU per vaccine by day 14. So this has been achieved in by day 14, more than to the comparator vaccine, and almost same by day 42. So but it says that it is non-inferior to the reference vaccine. Whenever we are taking with a new vaccine, we have to compare with a reference vaccine, and we say that it is a non-inferior vaccine to the vaccine which have already proved its efficacy. So coming to the safety, if you see the adverse events following immunization, it is less in comparison to the reference vaccine. So say for local adverse effects like say localized pain, redness, swelling, these are very less in comparison to the reference vaccine, that is rabies. For systemic adverse events also, for like say fever, headache, urticaria, joint pain, nausea, these are very less. So the novel 3-dose vaccine has better safety profile and also significantly less adverse events as compared to the reference vaccine, that is Rabipur. Next slide, please. So the study concludes that the novel 3-dose vaccine was non-inferior to the reference vaccine, as I said, with respect to the immunogenicity by day 14 and 42, and less adverse events compared to the reference vaccine. So as reported in the study that it has less adverse events to the comparative vaccine or the reference vaccine in the study. And more importantly, the only dose is 3 doses. That is, novel 3-dose was found to be safe and immunogenic and was comparable to the 5 doses of WHO pre-quality vaccine, that is the reference vaccine Rabipur. So the advantages is that it is non-inferior to the reference vaccine. It has less adverse effects and less pricks or only 3 visits. Next slide, please. So basing on this innovation, the Cadila Pharmaceutical has been awarded the Pharma Innovation of the Year by the Economic Times, the Indian Pharma World Awards, and the Golden Globe Tigers Awards Malaysia for Innovative Product of the Year. They have also achieved this achievement because of this innovation in the field of rabies vaccine production. That is the newest new G protein vaccine using the VLP technology. The brand is Travis. So with this, I conclude my talk. Thank you one and all for your patience hearing. Hope to continue with this scientific knowledge and the support of the new product with less adverse effects and more immunogenicity and less time visits. So those are many advantages with the newer vaccine. Thank you one and all. It's over to you, the organizers.
So thank you so much, Dr. Sir, for the informative talk. We truly appreciate your efforts. Last but not the least, as you have already mentioned, that Thabis has won the 2 prestigious awards in innovative category, ET Pharma Award and Golden Globe Tiger Award, sir. So thank you for your valuable time, sir. So thank you for valuable time, sir. Very soon we will meet and discuss more about